Good afternoon, everyone, and welcome to Alleviate's webinar series. And today we'll be discussing an important topic, interesting as well, intradiscal therapies for low back pain. So this is an overview of what we'll be covering today. Introduction, discogenic pain and its pathology, therapies, ablation, PIRFT, L-disc, coblation, biculoplasty, chemical therapies, and biologics. So introduction, intradiscal therapies are interventions in which agents, physical or chemical, are delivered into the intervertebral disc to stop or reverse pain. So discogenic pain, again, originally it was thought that intervertebral disc had no nerve supply and could not hurt until 1980s, 80 and 81, when it was confirmed that the outer one-third of the annulus fibrosus had nociceptors. Damaged and degenerated disc can attract ingrowth of new nerves which follow the blood vessels and granulation tissue. The other argument that was thought was that this intervertebral disc were innervated, but that was not nociceptive. The nociception was not there, as well vasomotor or sympathetic involvement was there. Discography emerged as a diagnostic tool which reproduced pain. The disc came to be one of the most potent source of low back. This we know because the cases which come to us are lower back pain. One of the most important causes discogenic pain. Disc stimulation is an adaptation of discography. It's an adaptation. Concentrates more on patient's response. Discography concentrates on determining the internal morphology of the disc. That is, you inject something and then you can take a CT scan. But those are not very relevant. Where disc stimulation, wherein you see if the patient is getting pain, the response of the patient is what matters actually here. Regenerative changes are quite prevalent and are of secondary importance. This stimulation, the operational guidelines is it should reproduce patient's pain, concordant pain. Stimulation of adjacent disc does not produce pain. Specifically, which disc you are concentrating. When you stimulate that disc, the pain has to, be reproduced. Pain is evoked at a low threshold, that is 20 psi. The evoked response is clinically significant on pain scale, that is more than 7/10 on your NRS. So pathology, lumbar disc responds to a variety of nutritional, metabolic, and mechanical insults. The disc matrix is produced by chondrocytes in the nucleus pulposus. Just a basic thing which I'll be telling is that nucleus pulposus is the one which is inside. Outer aspect is your fibrosis, annulus fibrosus, and they are made up of proteoglycans, more of in the nucleus pulposus, whereas and with collagen is less. Collagen is more in your annulus fibrosis. Annulus fibrosis has got multiple lamellae which are surrounding layered like ring like structures. This is fibrocartilage, and the content is collagen type 1 in your annulus and type 2 in your nucleus pulposus. And the collagen 1 basically is the reason for the tensile strength. And the nucleus pulposus has also got your proteoglycans, glucose aminoglycans. That is also the reason why that is formed by 80% of water, because these things attract water, the hydrostatic properties of it. So synthesis is promoted by tissue growth factor and insulin-like growth factor in the matrix. The matrix is normally renewed. Old matrix is degraded by metalloproteinases. Metalloproteinases are controlled by tissue inhibitors of matrix metalloproteinases. So this is how the basic pathology. When there is an injury, you have your phospholipase A being activated. That acts on your arachidonic acid, and prostaglandins and leukotriene are secreted, which again activate your macrophages. Macrophages again have TNF alpha. Why this all we are explaining is the reason is each of your therapy will be actually targeting one of these. So that is the reason why we are actually discussing it. And the most important also, the structure which is there is also of the matrix is your chondrocytes. Chondrocytes normally produce your tissue growth factor and insulin-like growth factor, which helps in synthesis of the matrix. That is broken down by your metalloproteinases. That is again in turn controlled by your tissue inhibitors. So what happens is when macrophages are activated, the interferon is also secreted, and in that your nitrous oxide synthesizes nitric oxide. It combines with your superoxide, which is again produced by your macrophages. and that again, activates your tissue inhibitors. So further degradation will be there. It actually inhibits your tissue inhibitors. Furthermore, the activity of your metalloproteinases is more, because of which there will be degradation of the matrix. So this is what exactly we'll be seeing in the subsequent slides, because it might be a little difficult to take down everything. So that's why I thought I'll just explain it. Injury disturbs this balance of synthesis and degradation. This is what we have understood. Injury causes liberation of phospholipase, which acts on arachidonic acid. Prostaglandins and leukotrienes are produced, which attract macrophages. Macrophages release superoxide and cytokines. In cytokines like TNF alpha, interferon, they also stimulate the matrix to produce more metalloproteinases and stimulate nitric oxide synthase to produce nitric oxide, which inhibits chondrocytes further. Nitric oxide combines with superoxide to form peroxynitrate, which inhibits the tissue inhibitors. So furthermore, increasing the activity of your metalloproteinases. This again, it's a diagram in which you can see that nucleus pulposus, you can see there is an irregularity of the pressure. Anteriorly, it's fine. Posterior annulus is under more pressure and stress. This is what this schematic diagram depicts. So nucleus pulposus is under stress. Nucleus degrades. It cannot retain water, loses hydrostatic property. Pressure in the nucleus pulposus, as we discussed, is irregular and reduces significantly. Load in turn increases on your posterior annulus. These are the two basis for your painful disc. Internal disc disruption, again a very important topic. Annulus buckles, the pathological or the cascade which we have discussed, post which the annulus buckles and delaminates. Progressive disruption of the annulus causes or leads to the radial fissure. These being the characteristics of internal disc disruption. The hallmark of internal disc disruption is the fissure. Grade 3 and 4 we'll be discussing. I have a diagram. 3 and 4 are significantly associated with pain on disc stimulation. So this exactly is grade 1, grade 2, in which the inner 1/3 has been breached, 1 and 2. Third, you can see that there is a radial fissure which has been formed and it is coming to your outer 1/3, and again circumferential spread in grade 3 and grade 4. That's the reason why these two are more significant in pain and cause of painful discs. This is again a post discography wherein a contrast has been injected. This is a grade 0. The patient has no pain in this case, and it has been injected, and a CT has been taken, in which you see that it is in the nucleus itself. Whereas here there is a radial, the fissure through which the spread you can see, and there is also a circumferential spread which is seen in grade 4. So modic changes. Modic lesions occur in the spongios of the vertebral body above the affected disc. So type 1 and type 2. Type 1, there is in which your T1, T2 weighted image, both it will be, there will be a difference, wherein in this, in fact, because there is a fat deposition, which is commonly seen in post-inflammatory problems. This is a T2 weight image, midline sagittal magnetic resonance scan, showing a high intensity zone, if you can see here, at a L4, L5 distal. This is what I was telling you about. This is type 1, this is type 2. In this image, a sagittal magnetic image, you can actually see that in T1 image, the modic changes, it is seen as darker, whereas in T2, it is seen brighter. Whereas in this, both T2 and T1 weighted images, it's the same. So this is basically fat deposition, which can occur post-inflammatory. So now we'll come down to because we have understood the pathophysiology or how it happens, the targeted things can be sought with these therapies. Again, ablation attempts have been made to denervate the disc at different sites. One of them is your rhamecommunicants. So little about the disc nerve supply. It is supplied by your sinovertebral nerves, which are again coming from your spinal nerves and the posterior aspect. And gray rhamecommunicants also supplies your disc. So this can be you can do an ablation of this nerve. Statistically significant differences arose in favor of radiofrequency treatment at 4 months of treatment. There was modest 46 mean decrease in pain, no reports of high-grade pain relief. Also, these patients received triamcinolone. That was also a reason why when you have actually done your radiofrequency, you would have injected. So it was not very clear that the pain relief was because of the lesion or because of that triamcinolone which was injected. So in which the controls had not received this corticosteroid. So intranuclear radiofrequency, the nucleus pulposus is devoid of any nerve endings. In intranuclear radiofrequency, there were probes placed within this nucleus to coagulate those nerves there. However, the proponents of intranuclear radiofrequency argued that the electric field produced around the electrode will be sufficient to destroy the nerve fibers in the annulus and thereby provide relief. But the cadaver studies dispelled it. So this is obsolete. We are not doing it. So yeah, percutaneous intradiscal radiofrequency thermocoagulation. It involves inserting a flexible radiofrequency electrode placed into the posterior annulus in order to coagulate fissures and nociceptors with heat lesion. Good results were reported in pilot studies. This was again a pilot study, which is a small study which they do, and however, control studies found minimal improvement in pain. Pilot study is a small study which you actually do, facilitating for the larger studies. So this cannot be, and control studies found minimal improvement of pain. Okay. Intradiscal electrothermal therapy. This was developed in 1900s, involved placing a flexible heating element in the posterior annulus. Observational studies, this was again an observational study, not an interventional, showed significant pain relief. The difference in observational studies is you are not doing anything actively in this. So, but two randomized studies have different results. One showed as the observational studies and the other found no effect. The popularity of intradiscal electrothermal therapy has evaporated because success occurred in a small portion of patient, and there were cases of increase of pain also. Exacerbation also was there. L-disc, it is a flexible. The difference in this as compared to its predecessors is that it was flexible. I have a picture after this. So that can be used to deliver lesion to the annulus fibrosis. It differs from the others predecessor, but that the tip of the electrode can be bent with an internal mechanical device in order to change the course. A single case series reported 11 of 20 patients treated with the device achieved 50% of pain relief for 24 and 48 weeks after treatment. So this is how the probe is. So you can insert it a little laterally, and this is bent. This is the difference between its other predecessors. This is how you are going to insert, and you can ablate. So ablation electrode is better than saline. It produces plasma field around the tip of the electrode. It can be used to dissolve and remove, ablate the tissue in discogenic pain. The tissue material can be removed from the radial fissures. No outcome data were reported on restoration of function. Again, something which is used now quite frequently is your biaculoplasty, wherein you use your cool radiofrequency ablation, and electrodes are inserted in opposite posterolateral corners of the annulus fibrosus of the target disc. The rationale is arching a lesion between the electrodes will ablate the nociceptors in posterior annulus. Taken into context, biaculoplasty is an entertainable option. It is remarkably safe to perform and tolerated well by the patient because it is temperature controlled. In this case, your temperature is not going very high, and it is remarkably safe for that. And at L5S1 level, again, the iliac crest comes, so there is technical difficulties and prevents optimal placement. Randomized controlled study showed superior effects over conventional management alone. 42% of the patients treated had 50% relief for 6 months, sustainably larger up to 1 year. Again, this is a fluoroscopic image in which you can see that the two electrodes are placed in the opposite direction. This lateral image shows that posterior lateral side of the disc, these electrodes are present. This is again a declined image in which the dotted lines point out towards the posterior aspect of the disc. This is how your lesion will be formed between the two electrodes. So now we come down to chemical therapies. So intradiscal steroids, because phospholipase A2, as we had discussed, has been implicated in disc degeneration and injury. Intradiscal steroids have a rationale. By inhibiting the phospholipase cascade is prevented, and interleukin and prostaglandins are not produced. Control trials did not show great difference in case of methylprednisolone 80 milligram and 1.5 ml of bupivacaine. At 1 year follow-up, there was no discernible improvements in disability. A different picture emerged for treatment in modic changes. Patient had significant pain relief from day one. This is again an important thing, wherein if the patient had modic changes, there was significant pain relief with your intradiscal steroids. Etanercept, tumor necrosis factor blocking agent, binds tumor necrosis factor receptors, which are produced again tumor necrosis factor by your macrophages. Placebo-controlled study assessed efficacy of 0.1 to 1.5 milligram dose. No difference was found. A second study with 10 milligram showed significant improvement at 4 weeks. However, at 8 weeks, the benefit extinguished. A single dose may not be enough. Methylene blue, it has a weak neurolytic effect, inhibits guanylate cyclase and nitric oxide synthase. In a pilot study, patient had good relief as compared to sham control group. Observational studies are not strong evidence, didn't have strong evidence. If results are positive, but if negative, they can constitute strong evidence. Antibiotics, again, a group of investigators explored that modic changes might be due to infection by aerobic organisms. A pilot study showed followed by a placebo-controlled trial of antibiotic therapy for back pain with herniated disc with modic lesions. Significant improvement was seen, but at 1 year, 67% still had pain. Later studies with ribosomal assays of the herniated disc material did not show any bacterial infection. So again, coming down to proliferants, substance used to enhance healing. Example, chondroitin sulfate, dimethyl sulfoxide, bupivacaine, and hypertonic dextrose glucosamine. So chondroitin and glucosamine have not shown any anabolic effects. Your dimethyl sulfoxide is a neurolytic, then restorative. Coming to biologics, something which again are used. These are elements naturally found in bone or bone marrow as cells or proteins which promote healing of connective tissue by in vitro or lab animal studies. They inhibit cytokines and degenerative enzymes. Sealant, a proprietary preparation of fibrinogen used in neurosurgery for controlling bleeding. It also inhibits cytokine and metalloproteinases. It can seal the radial fissure. A pilot study in 15 patients, 7 patients had more than 50% relief at 6 months, and that was sustained till almost 2 years. Next, platelet-rich plasma. It contains, again, your tissue growth factor, insulin-like growth factor, basic fibroblast-like growth factor, and platelet-derived growth factor. And multiple other growth factors are also present. They promote connective tissue healing and promote matrix synthesis. First study compared PRP to contrast medium. Significant difference in favor of PRP was found. An off-label study, 9 of the 22 patients, off-label study. By off-label study, what they mean is that both the participant and the researcher both know what has been administered. Has greater than 50% of relief coupled with 30% improvement in disability at 6 months. Alpha-2 macroglobulin, fibronectin aggregate complex, FAC. They are markers of cartilage degradation. FAC formation is inhibited by alpha-2 macroglobulin. Again, the people who prepare PRP only can be asked for this preparation. A study explored intradiscal effect of plasma rich in alpha-2 macroglobulin out of 24 patients in whom FAC were positive leakage. So this is what they've, there was a greater improvement in cases where FAC were positive when we have given alpha-2 macroglobulin. Stem cells, these have attracted greatest amount of attention. Abundant literature on effects of stem cells is available. They suppress the genes responsible for synthesis of degradative enzymes, increases proteoglycans and matrix, improves histological appearance of the disc, increases disc height, improves MRI appearance. Several small studies have been established the feasibility and safety. There have been several small studies. Observational studies found 16 of 26 patients achieved 50% of pain relief at 12 months, with 2 having complete relief, and it was sustained for up to 2 years. The other studies carried out were on the basis of MRI findings of degradation, which also covered asymptomatic patients. The success of intradiscal therapy can be improved if applied to painful disc on stimulation and modic changes, or high intensity zone, which I had shown you on that MRI. Thank you.
We can end the session, Doctor.
Hello.
Thank you. Yes, Doctor, we can end the session.
Hello.
Yeah, hi. Yeah.
Hi, sir. Very good afternoon.
Yes, sir.
Yes, sir. I just saw the presentation. It was an amazing presentation. A very new topic, I think, especially for our fellows, the intradiscal the intradiscal various options which we have for management of low back pain. So just having a couple of doubts here, sir.
Yeah, please.
With regards to the intradiscal PRP, what we have been seeing is the studies are in the nascent stage and it has shown a good amount of benefit. So for the benefit of the fellows, I just wanted to ask, like, what would be if there is any complications which can manifest, or they need to be careful if they are using the intradiscal PRPs? What do you think we should be careful of?
Yes, the most important thing is that sterility has to be maintained. And discitis is a very big problem in whenever you are actually getting into the disc. Discitis is a very, the complication, feared complication of, the injecting anything into the, not PRP alone, but anything at all into the disc. The feared complication is discitis. And as sir was also telling, there has to be further more studies. There has to be more randomized control studies in this regard for us to actually, more and more studies will make a better thing that because most of the things which we have seen, there are less randomized control studies which have actually happened.
True. And to the extent I totally agree with Dr. Wiquar that even the preparation of PRPs varies from place to place. So remember, very, very true that very importantly, we have to keep in mind that if you're planning of using PRPs, especially in the intradiscal region, be very careful about the formulation and the preparation as well. And one another complication which I had read, sir, is that in one of the studies they had shown that the platelet fibrin clot which has formed, it had actually dislodged and gone and aborted the... Hello, am I audible, sir?
Any other doubts?
Am I audible? Hello?
Yes, sir. Yes, sir. You're audible.
Yeah. I'm saying
I think
basically one another study I was going through regarding intradiscal PRP.
Yeah.
Over there, they had mentioned that the fibrin clot with the PRP which had formed intradiscal had dislodged and gone and accumulated in the lateral canal, leading to severe pain and stenosis, which required an emergency evacuation. So for the benefit of the fellows, what I'm trying to tell is the new therapies which are there, it's very important that we be aware of what are the effects and the side effects as well. And PRP, as of now, it is studies are still going on though.
Javed,
and
your voice,
very good.
Your voice
regenerative
was not heard. Yeah, please. There was some internet problem in the middle. I couldn't
yes, sir.
hear you.
Yes, sir. So what I was telling is I was having a look at one of the study, and in that with the intradiscal PRP, there was a
Sir,
case
can you
report.
please repeat your question? I couldn't.
Am I audible, sir? Hello? Hello?
Sir, you are audible to us, sir. I think Vicar, sir,
Vicar,
for
I
him it
think
is not
there is
audible.
some this one. So I think you guys have understood, right? So especially with the
Yes, sir.
PRPs,
There's
you
some
need to be
issue with
very
my
careful.
internet, sir.
Yeah, sir. These were the 2 points I just wanted to put it across. So other than that, it was a wonderful presentation, Dr. Vicar.
Yes,
I hope I'm audible to you.
Very important inputs, Dr. Javed.
Sir. So
Thank you.
of course, it was a very nice topic, intradiscal therapies. I mean, it is the recent advances now for treatment of back pain.